Hi everyone, this is Dr. Aurelie Najm from Glasgow reporting for REM now. I don't know what you have said about this last day of the conference. I hope you really enjoyed it. I actually did. And today we're super lucky because we have Dr. Giles with us from Columbia University. And he is here with us to discuss about the two big studies that we've seen yesterday, Abstract 1428 and today, Abstract 1915, about corticosteroids and cardiovascular risk. So just to summarize them very, very briefly, 1428, 26,000 US veterans, and 1915 Medicare database, about more than 130,000 patients. So I think the message is clear. What can you tell us about that, John?
Well, I think we have a lot of evidence from both from people who have rheumatic diseases and from the general population that corticosteroids are associated with cardiovascular risk, primarily because they're atherogenic. They increase blood pressure, they increase blood sugar, they induce diabetes, and they clearly have pro-atherogenic properties, despite the fact that they are anti-inflammatory, as opposed to most of the other medications that we use. So I think those data are very compelling, even though they are observational, and there's the possibility for confounding by indication, because the people that you give the highest doses, at least, of corticosteroids are the folks that probably have more inflammation. So there's probably some element of confounding by indication that we see here. So the magnitudes may not be, the true magnitudes may not be quite as great, but it's hard to explain away the magnitude with just confounding by indication.
Yeah, no, definitely. I mean, I think it would be quite interesting. Do we have any data where actually the analysis was adjusted on disease activity? Do we have any of that?
It's harder to do from these types of data sets, especially the large administrative claims data sets, because we don't typically get that amount of information. And it's not just, the issue is that when people are on corticosteroids, there are different reasons that they're on. Most patients with RA who are on low-dose corticosteroids are not on low-dose corticosteroids because of the inflammation that they have today. They've been maintained on a low dose of steroids for a long time. So in those people, the confounding by indication probably doesn't make that big of a difference, or is not playing as big of a role. Now, when we're getting into the bigger doses, then those are the folks who are probably have just been put on that dose. There's all the issues of tapering. There's all the issues of whether they're really taking their doses. I know in my experience that when I write a steroid prescription, it's not usually written exactly the way I intend them to take it, because I often want them to have a little extra just in case, they need it at some point. Yeah. So those types of claims are, you can't really exactly tell from those. So I think it really makes this type, there's a lot of wiggle room in terms of what the actual numbers are, but there's a dose effect here, and it's pretty profound. So I think that there's definitely some truth to this, and it's not just explained by confounding by indication.
Yeah, no, and coming back to that dose effect, I mean, it was quite interesting to see how things increase very gradually, and there's already a increase in the risk below 5 milligrams a day, because I've heard that for so long. I remember when I was a resident, I was hearing, below 5 milligrams, that's fine, you can keep going. And actually, it doesn't seem to be true. Also, what was coming from the other abstract was the short duration of treatment that could have already an impact. What do you think about that?
Yeah, I think it's there is probably some patients in whom very short courses of steroids, especially if they're at relatively high doses, might be enough to tip some people over the edge. The mechanism by that is maybe not quite so clear. If you have a sudden rise in blood pressure in a person who has a lot of vulnerable, unstable plaques, that could be something that that changes things around. There's a lot of fluid shifting. Maybe they could go into a heart failure exacerbation, and that could shift things. So that on an individual basis, then it might make a difference. We're not looking at thousands and thousands of events in these studies. We're still looking at relatively rare events. So it's not as, and it's something that you're probably not going to see in your own experience. You're going to give lots and lots of courses of steroids and everything's going to be fine. And you're going to say these drugs are fine. But, there's the cases that if you conglomerate everything together, you're going to see that they're increased. Now, again, recognizing that these are not randomized and that understanding treatment effects is difficult in these types of studies, but there does seem to be a signal through multiple different lines of evidence, VA, prior studies, administrative claims. It's something that seems to be a fairly consistent theme.
Yeah, and from different methodologies as well, different cohort, different population. I mean, I think I agree with you. I think this is quite clear. So now the question is, what are we going to do? Are we going to tell all our patients, right, you need to stop your steroid?
I think it's really difficult. I tell my patients and I tell my colleagues, it'd be great to live in a steroid-free world. Not just from the standpoint of inflammatory arthritis, but from the standpoint of diseases like the vasculitides, where we have to use really high doses of steroids in people who are at quite high risk for cardiovascular disease. Well, we have to do it that way. So as the recommendations, the EULAR recommendations for cardiovascular risk is to keep, the lowest dose that you can get away with of both steroids and NSAIDs is what we should do. The other is, how to get people off of steroids as well. And that can be a big challenge because, the short and medium term period after tapering steroids is not great for people. A lot of people who have been on steroids for a long time, even small doses. And it's hard for them to know that if they just stick it out a little bit longer, or if we taper a little slower, that they're going to be successful in getting those off, because they really do. They feel tired and washed out and fatigued, and if all it takes is pop in another 5 milligrams of prednisone and that instantaneously goes away, that's a real reinforcer for our patients to stay on the drugs despite our best efforts.
Yeah, absolutely. I mean, I've been on steroids once in my life, and I never wanted to go out of them. I mean, that was great.
Yeah, because they can have a stimulant effect in people even at lower doses, and taking them away really can feel pretty crappy for patients. I think there have been some efforts to show that very slow tapering, even by half a milligram of prednisone, over weeks at a time, is a strategy for doing that. But it takes a lot of dedication, and then the very next flare, here we are again in the same position. So I also tell people that I couldn't be a rheumatologist without using steroids. We just could not work our jobs without this particular drug. So I think, we have to use it as carefully and safely as we can. And also recognizing, who are the people for whom we have some more leeway in using the low dose steroids, and then who are the people who are probably going to benefit the least, at least from a safety perspective.
I definitely agree with that. Why do you think these results were more, at least more significant, or just significant in the oldest population? Why do you think it's not reproduced in the youngest one, especially in the 1915 abstract? In the outcome data?
I think it's because the effect of the steroids is, especially for most people, is going to be over a longer period of time. The atherogenic properties of steroids don't happen very quickly. They're really over a longer period of time. So and in people who probably already have some atherogenesis that's already started. So while we talked about, there may be some people who take the shorter course of steroids and then that pushes them over. Probably most of the effect is more of a chronic pro-atherogenic effect, and that's what you're seeing in the longer term when you're looking at people on longer term doses.
Okay, so I think that was very informative. That's very nice. Thank you so much for being here and chatting with me about that topic. I really hope that next year we're going to be able to all meet face to face, especially since we've been discussing this just before we started this interview. We need our step counts in a day.
Right.
We need to be in the conference for our cardiovascular risk.
That's right. I usually get, something like 25,000, 30,000 steps in during the ACR meeting. And here I'm getting, from between here and the refrigerator. So that's not good for any of our hearts.
All right. So thank you so much. Thank you everyone for watching this video. Go on remnow.com for more scientific rheumatology content and follow me on Twitter at Aurelie Raimo.